Okay, can you see my slides?
Yes, we can see them.
Okay, good evening and everyone. And my name is Wu Zixiang from China. And my topic is the treatment option of cervical fractures with ankylosing spondylitis and their clinical efficiency. And this is a national multi-center study. And as we all know, and AS-related cervical fractures are not very common, but very challenging. The best treatment option is still controversial. So the objective of this research is till now, no multi-center study focusing on this special fracture in China is carried out. So in this study from 2003 and to 2019, 25 hospitals joined in this multi-center research, and about 454 patients were included in this study. As we can see in these two pictures, most fractures occurs in C2, C5 to C7, and about 77% patients receive operations, including anterior approach, posterior approach, and combined approach. As we can see the result, the overall survival rate in the surgical group was significantly higher than that in the non-surgical group. In the surgical group, the survival rate in adult patient, which means the patient age is more than 65 years old, was significantly higher than that in the elderly patient. The survival rates of the patient with incompleted spinal cord damage was also higher than those with complete spinal cord damage. And in this study, we can see in our study, we found the complication rate is very high, about 35% in the surgical group. It was a little lower than that in the non-surgical group, but there was a significant difference. Similarly, no significant difference was detected between the different surgical approaches. And our study also established a Cox risk regression model. According to the statistical analysis result, the main risk factor for the patient death include first is the age more than 65 years and the severe spinal cord damage, and the fracture location was ranged from C5 to C7. And in conclusion, no matter surgical or non-surgical treatment, the complication rate was very high than the common fractures. And the second was the patient younger than 65 or with incomplete paralysis. Surgery can promote neural function recovery and improve the survival. The third was choice for a surgical approach that has no significant effect on the prognosis. And the last one was due to the choice of a surgical approach that has no significant effect on the prognosis. So due to the limited time, it is difficult to fully explain this research. So if anyone who is interested in this study, you can contact us, and that is welcome. So thank you. That's my slide and my report.
Thank you very much. Thank you for that wonderful top abstract presentation. I'd like to have our next presenter present. This is Dr. Prasad on revision craniovertebral junction surgery. And then I'd like to have our next speaker, the following speaker, our third and last oral paper. This is Mohammed Rafai from Pakistan. Could you be ready to present immediately following? Dr. Prasad.
Good evening, respected moderators and professors. I would like to thank the society for allowing me to present on this platform. Craniovertebral junction and the intricate anatomy is fascinating to one and all, and the surgery is very intriguing. But most often, we see a surgical failure, which is an outcome of a poor surgical decision and an incompetent surgical technique. The failure of the surgery is devastating for the patient, and therefore it is very key to understand the causes of failure in these patients. Most often implicated cause in these patients is the surgical inclusion of more than required surgical segments and spinal fixation. The occipital squama is a thin strut of bone which has been implicated as the most common cause for the failure of these surgery in these patients, and also inadequate preparation of the host graft result in inadequate bony fusion. The only indication of surgery in these patients, either primarily or in a redo surgery, is progressive neurological worsening, non-fusion of the facet joints, and a persistent facetal instability. As has been emphasized multiple times in literature, atlantoaxial facetal fixation and atlantoaxial fixation arthrodesis is the treatment option for these patients. And no matter how much instrumentation is achieved at the cervicocraniovertebral junction, if the fusion at these joints is not adequate, the entire construct is bound to fail. We have been fortunate enough in dealing with a large number of patients at our center who all of these patients have undergone fixation previously by some or the other fixation techniques which have been documented and confirmed in literature. And all of these patients worsened subsequently after the first procedure, which itself signifies that the surgical technique was not correct. Out of these 41 patients whom we treated post first surgery, the implant needed to be removed in 13 of the patients to allow our fixation to take place, and only a unilateral fixation could be achieved in 10 of these patients. It is important to understand that a bilateral fixation is not mandatory, and even a unilateral fixation may achieve relief of symptoms in these patients. It's not only the cord compression or the deformity which is important, but the most important aspect while treating these patients is of instability at the atlantoaxial joint, which needs to be addressed. The key aspect of surgery in these patients in redo surgeries is removal of the construct if required, with an adequate exposure of the atlantoaxial facetal joints, which definitely is not easy because of extensive scarring and partial or improper irregular bony fusion due to the first surgery. Denudation of the joint capsule and introduction of the bone grafts is the most important part of the surgery because this is what determines the surgical fusion at the joint. And screw placement augments the stability, and exposure of the joint, though difficult because of scarring, must be done if a surgical cure has to be achieved in these patients.
1 minute left.
So in all these patients, irrespective of the previous surgery done, we were able to achieve a realignment of the bony anomaly and an atlantoaxial fixation, lateral mass and a pedicle screw fixation at the atlantoaxial joints. And all of these patients recovered after surgery with no complications in any of these patients, which leads us to believe that atlantoaxial fixation still remains the most important aspect while treating patients with craniovertebral junction anomalies. And to conclude, a failure of fixation following implantation with a lot of metal at the junction is a very challenging surgical issue, but is completely devastating for the patient. And though difficult, a revision surgery for a failed previous attempt is gratifying, a life-saving, and most probably the only surgical technique which can be offered to these patients for a surgical cure. Thank you.
Thank you very much for your wonderful presentation and top abstract. I'd like to introduce the third speaker in the top abstracts before the open papers. This is Mohammed Rafai, who will present on delayed presentation and carry malformation in the Pakistan population.
Hello everyone, I am Dr. Mohammad Rafi and my topic is delayed presentation in carie malformation. Carie malformations are a group of different pathological entities with a variable clinical presentations, and each having their different pathophysiological mechanism leading to the different outcomes. In 1891, a German pathologist, Professor Hans Chiari, was the one who first described this condition. This is basically a developmental malformation of the occipital mesodermal somoid. These are some subtypes of the carie malformation depending on the structure and the degree of herniation through the foramen magnum. The clinical presentation is either due to compression of the cerebellum or the brainstem, or the presence of syrinx, hydrocephalus, or the hydromyelia. The most common presenting symptoms is the occipital headache, which was reported in up to 80 to 100% of the cases in previous studies, followed by the retroorbital pain, tinnitus, and dizziness. The initial signs at presentations are downbeat nystagmus in majority of the patients, balance difficulties, swallowing difficulties, and autonomic disturbances described in the previous studies. The rationale of the study is to observe the different clinical presentation of patients in our population, as the time of initial presentation to the clinic is much delayed. That might change the subset of the signs and symptoms with which the patient presents. In demography, the majority of our patients were male and belonged to the first and the second decade of the life. The motor weakness is the commonest symptom at presentation in our population, followed by the motor weakness and the sensory deficit, and a very small amount of the patient had presented with the occipital headache. The commonest signs at the presentation in our population were ataxia and increased reflexes, exaggerated reflexes, followed by nystagmus, presence of Hoffman sign, and the spasticity. The chart below further describes the pattern of the motor and the sensory deficits in our population. Majority of the patient present with the upper limb weakness with a patchy sensory deficit. These are some conditions that are associated with the carie malformation, and in our population, majority of our patients had MMC and tethered cord syndrome associated with the carie malformation. And in our 60% of the patient, they have the radiological evidence of the cervicodorsal syrinx and the presence of the hydrocephalus. So in conclusion, the clinical presentation in our population differs from the others because of the delayed initial presentation that might be due to lack of awareness, lack of knowledge of the disease, and perhaps due to limited medical facilities. Thank you.